Good morning, everybody. Thank you all for joining us for our second session of our day. My name is Shelley Ryan, and on behalf of the Board of Directors, I'm so happy that you're all joining us for our summit. Our next session comes from the Regional CMS office, and we very much appreciate his time today. Dexter Glasgow has been employed with the Centers for Medicare and Medicaid Services since August 2015, and more recently with the Philadelphia Regional Office as of November 2020 as the Rural Health Coordinator Outreach Specialist. Dexter has a Bachelor of Science in Healthcare Administration from Franklin University, Master's in Human Resources from Penn State, and a Master's in Project Management from Georgetown University. Let's welcome Dexter Glasgow.
Thank you so much, Kelly, for that great introduction. And good morning, everyone. On behalf of my boss, Sharon Graham, who is the Regional Administrator of Philadelphia CMS Regional Office, we thank you so much for this opportunity. So without further ado, I'll get into the presentation. I will also answer all questions at the end of the presentation. I'll go ahead and take myself off camera here just to save some bandwidth to make sure we have a smooth presentation without no glitches. So I'm going to go ahead and hide myself here, and I will go into the presentation. All right, so here's a brief disclaimer here. So what I'm saying here is just that at the time this presentation was made, all the stuff here, all the material was relevant. So therefore, before you make any decisions, please go ahead and look at the references that's in the presentation before you make healthcare decisions, so that the employees, the agent staff of CMS, we don't guarantee that the decision you made from this presentation will be relevant. All right, so today's topic, we're going to go over QPP, traditional MIPS, the 4 parts: quality, performance category, cost, performance, improvement activities, final scoring, then MIPS values, briefly on evaluation management, briefly on COVID vaccine, booster shot, marketplace, then into questions. So let's go ahead and start with traditional MIPS proposals. Okay, so the MIPS program, it's just a program that assesses clinicians' performance on the 4 distinct areas, which are quality, cost, improvement activities, which deals with continuous improvement within an organization, and promoting interoperability, which focuses on the usage of certified EHR technology. And as you can see on this slide, each of these 4 categories have a weight associated with it, and that sums up to a total of 100 points. That becomes important because we assign to each clinician under the MIPS program something called a final score, which is based off of your performance on these 4 categories. The performance threshold we have proposed for calendar year 2022 is 75 points. So what that means is clinicians who fall below the score of 75 points will get a negative adjustment, meaning a penalty and a reduction in their claims, so less money. If your score is above 75 points, you will get a positive adjustment or more money on your claims. And if your final score is 75 points, you will get a neutral adjustment. So CMS is issuing a clarification about fiscal year 2021 performance category weights for APM entities. We have introduced some new terms which we think about a quality payment program, including traditional MIPS and our MIPS value pathways, and then the APP and how those performance category weights work. As you can see on this slide here, the gray columns are our performance category weights for traditional MIPS for 2021. For all clinicians that are not participating under the APP or not part of an APM entity, their performance category weights will be 30 points, each for quality and cost, and then 15 and 25 points for improvement activities and promoting interoperability. So looking here at the definition of the eligible clinician types. Definition of physicians include doctors of medicine, osteopathy, dental surgery, dental medicine, podiatry medicine, and optometry. So we've proposed to expand our set of MIPS eligible clinicians to the last two clinician types that the law allows us to expand to, which includes clinical social workers and certified midwives. So assuming this policy is finalized, we will have full expansion of our MIPS eligible clinicians. And as a reminder, the comment period closed back in September, and we're hoping around mid-November, which is about another month from now, we should have the finalized policies on this. This policy should be finalized by next November, sorry. Not next November, next month, November. Okay, traditional MIPS proposal and the quality performance categories. So CMS issued a request for information regarding the draft COVID-19 vaccination by clinicians measure specifications. And this is based on pretty much these, the 5 quality measures and these 2 administration claim measures we have here. The risk standardized admission rates for patients with heart failure for the merit-based incentive program system. So this is based on a 21 case minimum, 1-year performance period from January 1st to December 31st. It applies to MIPS eligible clinicians, groups, and virtual groups. Then looking at the clinician and clinician group risk standardized hospital admission rates for patients with multiple chronic conditions. It's an 18 case minimum, 1-year performance again from January 1st to December 31st. It applies to MIPS eligible groups with at least 16 clinicians. Moving on to cost performance category. Here we speak about the total per capita cost measure, the Medicare spending per beneficiary clinician measure, and the 18 existing episode-based cost measure remain in place as per the final rule this year, 2021. We have proposed 2 changes relevant to the cost category. The first listed here is the inclusion of 5 newly developed episode-based cost measures. These include 2 procedural measures that address maloneal resection and colon and rectal resection, a simple acute inpatient measure addressing sepsis, and 2 of our first chronic condition measures addressing diabetes and COPD. As we move on to improvement activities performance category, we're going to discuss now revising the criteria for nominating an improvement activity through the call for improvement activities process that we have each year. Our current policy is it only requires one of our criteria to be met in order to submit a nomination for a new improvement activity when we begin the program. We believe now we need to go ahead and increase the requirement since stakeholders have had a chance to become familiar with the criteria and understand how to submit a new IA. As such, new activities must meet the following 8 criteria, which are 2 proposed and 6 existing. The first will be relevance to an existing improvement activity subcategory or a proposed new subcategory. The second, importance of an activity toward achieving improved beneficiary health outcomes. Third, feasible to implement, recognizing importance in minimizing burden, including to the extent possible for small practices in rural areas or in areas designated as geographic health professional shortage areas by the Health Resources and Service Administration, or HRSA for short. Number 4, evidence supports that an activity has a high probability of continuing to improve beneficiary health outcomes. It can be linked to existing and related MIPS quality, promoting interoperability and cost measures as applicable. And 6, CMS is able to validate the activity. Here we propose just a few changes to the IA inventory. We've added 7 new improvement activities. Of those, 3 are related to promoting health equity. We're modifying 15 current improvement activities. 11 of those address health equity, and then we're removing 6 previously adopted activities. These are mostly incorporated in the modifications. We're just streamlining the inventory. Okay. In the promoting interoperability performance category, here as you view the central column, we currently reweigh all these different clinician types, and we propose to continue and extend that into 2022. We are also proposing to extend the automatic reweighing to clinical social workers. We did not propose to re-rate the certified nurse midwives because of their experience with our measures through the Medicaid Promoting Interoperability or EHR incentive program. We are changing our policy for small practices. So that we have to decide to do this for this year is to revise our reweighing and redistribution policies, particularly for small practices, to ensure that those small practices can have a more equitable playing field. So in circumstances when the promoting interoperability performance category is reweighed for small practices, quality will count for 40 points, cost for 30 points, and improvement activities for 30. In circumstances when both promoting interoperability and cost are reweighed, so assuming we finalize our small practice automatic reweighing policy as proposed, and if there are instances where we can't calculate costs, the small practice final score would be assessed off of the weight of quality of 50 points and improvement activities for 50 points, assuming we finalize as proposed. So once again, all we're saying here, this is what we're proposing. These current changes are on review right now, and we will know more about this come next month. So right now, we give clinicians a choice of submitting 2 of the 5 registry reporting options. In the proposed rule, we are modifying this mainly due to the data needed to address the pandemic. So we are going to require immunization registry reporting and electronic case reporting. I will note that both of these registry reporting options do have 3 exclusions. So if you qualify for one of those exclusions, you can claim that. And in addition, we are offering bonus points, 5 bonus points if you submit to one of the 3 remaining registry types, which are the public health, the clinical data registry, or the syndromic surveillance. So what we're doing, we have a couple more modifications for promoting interoperability. One is we're going to provide patients electronic access to their health information measure. It's going to be safety assurance factor for the EHR resilience guides or safer guides. We're modifying our information blocking at a station statement. Currently, there are 3 different statements that you need to attest to, and we're proposing to remove 2 of them. And for the final scoring proposal, we've established or proposed a performance threshold for the next year. That's 2022 to be at 75 points. Although this is the year that the law requires us to establish the performance threshold based off of a year's prior data period, as well as the methodology of the mean or median. So we are proposed to use the mean methodology, and we have proposed to use the first year's data that we have available to us, which was calendar year 2017. So one item I do want to flag is that in 2022, it will be the last year that we have our additional performance threshold for exceptional performance. So if you look at the right-hand side of this slide, I'm going to start at the green row in the middle. So 75 points. That's our performance threshold we have proposed for this upcoming year. Going down the table, you can see that clinicians whose final score fall below that will get a negative payment adjustment, as stated in an earlier slide. So then less money on your claims. For those whose final scores are above the performance threshold of 75 points, they will get a positive adjustment. And those final scores above 89 points will get additional performance threshold. And again, 2022 is the last year we have that set of bonus money that will be available. Okay, moving on to MIPS value pathways. So the 2022 NPRM proposed 7 MVP candidates, as well as various policies to support implementation beginning with the 2023 performance year. So our intent with this delayed time frame is to provide practices the time they need to review requirements, update workflows, and prepare their systems as needed to report MVPs. Therefore, the first year that they would be available for reporting would be the 2023 performance year. Now, the first 2 years of MVP reporting will be 2023 and 2024 if finalized as proposed. And we are proposing a new term called MVP participant. And that term just is meant to encapsulate the following clinician types: individual clinicians, single specialty groups, multi-specialty groups, subgroups, and APM entities. Another area of the MVP proposed timeline that we've laid out is a proposed rule is a timeline in which, starting with 2025, multi-specialty groups will be required to form subgroups in order to report MVPs. This is to get us to a point where clinicians within a group are really reporting on measures that are more meaningful to their direct practice and maybe not so relying on the performance of a few clinicians of the group, but rather than really having data they can utilize to make quality improvements in the care they provide to their patients. In calendar year 2021 PFS final rule, we established a set of criteria for use in the development and selection of MVPs. Specifically, we finalized that we are not prescriptive on the number of quality measures that are included in an MVP. Through this rulemaking cycle, we proposed in reporting requirements for MVPs and discussed the allowance of clinician choice in selecting which quality measures and improvement activities to report. The requirements for an outcome measure or a high priority measure when an outcome measure is not available is something that most MIPS eligible clinicians are familiar with. A given MVP may be attributed to one specialty or several specialties. So in an instance, an MVP is attributed to several specialties. Perhaps it's created and implemented in a manner that emulates the term-based care model, where there are several specialties involved. We will want to make sure that each MVP has at least one outcome measure that is relevant to each clinician's specialty that is included within that given MVP. We are aware that there might be instances where outcome measures may not be available, and so in these instances, we would like to be sure that there's inclusion of a high priority measure that is relevant to the MVP topics, so that the MVP participants can be measured on the high quality measures in instances where outcomes are not available. We will allow, when appropriate, utilization of these outcomes-based administrative claims-based measures within the quality component of the MVP. Now, that's not to say that the requirements of all MVPs, but when it's there and it's applicable, it can be used. And the last is more of a reminder with the utilization of QCDR measures in MVPs that the QCDR measures must be fully tested at a clinician level prior to the MVP being finalized and clinician level prior to the MVP being finalized and available for the upcoming performance period. So with the establishment of the MVP development criteria and the implement of MVPs, we anticipate that in order for us to understand the uptick on MVP reporting and also tracking, we want to establish a registration process. So for example, for the 2023 performance period, MVP registration will begin on April 1st, 2023 and end on November 2023. We have built out some flexibility in case there is an advertent circumstance that is unplanned for, which would cause us to extend the registration time period. So it may be a later date as specified by CMS, but for the time being, we are planning for there to be a consistent time period of April 1st to November 30th. After the November 30 deadline, we will not be able to accept any additional changes. We will not be able to allow for the reporting of an MVP that a given MVP participant did not register for. MVP candidates. The MVPs support patient-centered care, a continued emphasis on the importance of patient outcomes, population health, health equity, interoperability, and reduced reporting burden for clinicians. We recognize that there are many types of MVPs we need to develop, and that a traditional MIPS framework is needed until we have a sufficient number of MVPs available. Through the MVP development work, we'll gradually implement MVPs for more specialties and subspecialties that participate in the program. I ask you to please refer to the proposed rule appendix, where we include the details of these MVPs, including which measures we propose to include in each. For the MVP scoring, we believe and propose to include subgroups in the scoring hierarchy would allow for meaningful data collection and assessment under MVPs, while applying our existing policy of allowing clinicians to receive the highest final score and payment adjustment that can be attributed to them. What we're saying is if a given MIPS eligible clinician chooses to report on the MIPS value pathways, but then also decides to submit data through the traditional MIPS means, both will be calculated and the highest score will count as the final score. As I said earlier, the comment period closed on 9/13, and we'll have the final rules sometime in November if all goes well. We will provide more details in meetings or presentations in 2022. So here is just where you can go for additional resources if you need this web link has additional resources that you can go to if you need more information on QPP. So I just want to touch quickly on evaluation and management. This was requested in a few presentations I had pertaining to practices. Just want to clear up a few things here on E&M services. So we are proposing to refine our long-standing policies for critical care services. As such, in calendar year 2022, PFS proposed rule, we are proposing what is shown on this slide here, which is pretty much to use the AMA procedural terminologies, allow critical care services to be furnished as split or shared visits, etc. These 5 points there, this is what we're proposing. As it relates to teaching physician services, the AMA CPT Officer Outpatient EM Visit Code and Framework that CMS finalized for 2021, under which practitioners can select the Officer Outpatient EM Visit level to bill, was based either on use of the total time personally spent by the reporting practitioner or medical decision making. Under our existing regulations, if a resident participates in a service furnished in a teaching setting, a teaching physician can bill for the service only if they are present for the key or critical portion of the service. Under the so-called primary care exception, Medicare makes PFS payments in certain teaching hospital primary care centers for certain services furnished by a resident without the physical presence of a teaching physician. CMS proposed to clarify that the time when the teaching physician was present can be included when determining EM visit level. Under the primary care exception specifically, only MDM would be used to select the visit level to guard against the possibility of inappropriate coding that reflects residents' inefficiencies rather than a measure of the time required to furnish the service. Here I'm going to touch briefly on the COVID-19 booster shot, as this is becoming a hot topic. Here it's important to know that ACIP and CDC's recommendations are bound by what FDA's authorization allow. At this time, the FDA's Pfizer-BioNTech booster authorization only applies to these select populations who receive the Pfizer vaccine as their primary series. People in the recommended age groups who receive the Moderna or J&J Janssen vaccine will likely need a booster shot, and more data on the effectiveness and safety of these booster shots are expected in the coming weeks. So looking at the CDC recommendations here. So this decision followed a careful examination of the latest data and robust and deliberative discussion around booster shots. This includes data from a small clinical trial that showed a booster dose of the Pfizer COVID-19 vaccine increased immune response in those who completed a primary series 6 months ago. Among adults 65 years and older, data show vaccines remain effective in preventing hospitalization and severe disease, but recent evidence suggests they are less effective in preventing infection or mild symptomatic illness due to waning over time on the Delta variant. and emergent evidence show that among healthcare and other frontline essential workers, vaccine effectiveness is winning against COVID-19 infections. So pretty much here, this slide just shows people who received the Moderna and Johnson vaccine, what they should do. We're still waiting on data from that to go ahead and give a green light on booster shots. So the important part here, payment. So when you look at the slide, it has some payment rates here. So these rates reflect updated information about costs involved in administering the COVID-19 vaccine for different types of providers and suppliers, and the additional resources you need to safely and appropriately administer the vaccine. We generally implement changes to Medicare payment rates for specific services through notice and comment rulemaking. In this case, however, we implemented the payment rate changes for those specific services to respond quickly to new information during a public health emergency. Please note these rates do not apply if Medicare pays you for preventive vaccines and their administration at reasonable cost. For example, federal qualified health centers and rural health clinics and hospital-based renal dialysis facilities. As usual, there's no other costs of pocket for your patients. In addition, you also can balance bill for COVID-19 vaccinations. You can charge your patients for an office visit or other fee if COVID-19 vaccination is the only medical service given. And you can't require additional medical or other services during the visit as a condition for getting a COVID-19 vaccine. So administering the vaccine in patient's home. Medicare will pay the $35 amount in addition to the standard administration amount, which is approximately $40 per COVID-19 vaccine dose, for a total payment of approximately $75 for a vaccine dose administered in a patient's home. We also geographically adjust the additional amount and administration rate based on where you administer the vaccine. We established a $35 payment amount on a preliminary basis to ensure access to COVID-19 vaccines during the PHE. We continue to evaluate the needs of Medicare patients and these policies, and we'll address them in the future as needed. Now, unlike the requirements under the Medicare home health benefits, you or another allowed practitioner don't need to certify that the Medicare patient is homebound. But you must document in the patient medical record their clinical status or the barriers they face to getting the vaccine outside the home. We're going to take a look here at locations that pertains to in-home payment. These locations don't qualify as a home for the additional payment amount. So prior to August 24, 2021, communal spaces of a multi-unit living or communal arrangement, hospitals, except when Medicare patient's home has been made provider-based or hospital during the COVID PHE, Medicare skilled nursing facilities, and Medicaid nursing facilities, regardless of whether they're patients' permanent residents. So once again, these are locations that don't qualify as a home for additional payment amounts. Now, let's look at electronic prescribing of controlled substances. Section 2003 of the Sport Act requires electronic prescribing of controlled substances for Schedule 2, 3, 4, and 5 controlled substances covered through Medicare Part D. The statute provides the Secretary with discretion on whether to grant waivers or exceptions to the EPCS requirement and specifies several types of exceptions that may be considered. It also gives the Secretary authority to enforce non-compliance with the requirement and to specify appropriate penalties for non-compliance through rulemaking. In December 2020, CMS implemented the first phase of this mandate by naming the standard that prescribers must use for EPCS transmissions and delaying compliance actions until January 1st, 2022. Okay, I just want to touch here briefly on enrollment. So as you know, right now, we're exempting certain types of independent independent diagnostic testing facilities from several of our IDTF supply standards. And this all pertains to provider enrollment. You can establish your authority to deny or revoke a provider's supply Medicare enrollment, or you can establish specific rebill procedures and regulation to providers and suppliers whose Medicare billing privileges have been deactivated. We don't want you to forget about flu. It is the flu season, so please make sure that we keep getting this message out, that people get their flu as well as COVID when needed. And lastly, we are marketplace enrollment. I do know Pennsylvania, you have Penny, where you direct your clients to. And that starts from November 1st to January 15th. As you see, the January 15th date, that has been expanded by a month. And, it's the SCP we had earlier this year that ran until August was very successful. And it gave a lot of beneficiaries a chance to get some really low payment rates for their Medicare. So we just ask you to get the word out, try to encourage your clients to sign up. Lastly, feedback. If you have a moment, please take this website down, provide me some feedback on how I did, the information that was provided, and other information there. And for you folks who are handy dandy with a smartphone, you can click on this, and this will also provide you feedback. So with that said, I am open to questions.
I'm not seeing any questions at the moment. There's some resources from Dexter.
Okay, well, if there's no questions, I want to thank you for your time and thank you for your invite. And I hope this information was useful. And by all means, feel free to reach out to me should any questions pop up.
Yeah, I want to thank Dexter especially. He's been very helpful in accommodating our schedule. He was very helpful to me in scheduling. So thank you very much, Dexter.
You're welcome, and all the best for the remainder of the week.
Thank you,
Thanks.
Dexter.
Okay, take care, everyone.